Good evening, everyone. On behalf of Inter Pharmaceutical Limited, I, Dr. Mithilesh Nayak, once again welcome you all to this Endocrine Talk Show episode 7. And today we are going to discuss about the various aspects on the new guideline which are recently published in the management of type 2 diabetes mellitus. We have now recently published ADA ESD Concessions 2022. We have American Association of Clinical Endocrinologists guideline for the management of diabetes, and we also have RSSDI latest practice management guideline as well. So, how this is going to change our practice? What are the challenges in implementing this guideline in Indian context? That we are going to discuss today, and to help us and to moderate today's session, we are having with us our host director for the program, Dr. Subhankar Chaudhary sir. He is a professor and head at Department of Endocrinology at SSKM Hospital, Kolkata. Uh, he was a former he is a former editor in chief for Indian Journal of Endocrinology and Metabolism.
I think we can skip all these.
Sure, sir.
Make it short. Make it short. Yeah.
We are fortunate to have with us Dr. Subhankar Chaudhary sir. So without a further ado, I hand over the session to Chaudhary sir and request him to introduce our panelists for today's program. Over to you, sir.
Thank you very much. Been a wonderful journey with Endocrine Talk Show. Initially, the pearls in endocrinology, which have been going on for the last 2 years or so. And each time we are, let's say, blessed with the presence of excellent experts from across our country. And this evening is no exception. And we have none other than Dr. Anil Vansali, who is currently Director, Guinea Health at Mohali, who was not too long back head Department of Endocrinology at the PGI Chandigarh. And we all know has so many publications, so many awards, and also a former president of the Endocrine Society of India. We also have with us this evening Dr. Subhash Wangnu, who is senior consultant endocrinologist at the Apollo Center for Obesity, Diabetes and Endocrinology at the Apollo Hospital in Delhi. And he's been involved in teaching and training of DNB endocrinology students for more than 10 years. We are also fortunate to have with us Dr. Rajesh Rajput, who was not too long back head in the Department of Endocrinology at the PGI Institute of Medical Sciences at Rohtak, and now he's heading the Department of Endocrinology at Kainos Super Speciality Hospital in Rohtak. He's also published widely as a very respected and renowned endocrinologist of our country. He's been a past president of Indian Thyroid Society, ITSCON. We also have from Bangalore, Dr. Vagish Iyer, who is a professor in the Department of Endocrinology at St. John's Medical College and Hospital. He was a former head in the same department. He's president of Karnataka Endocrine Society, and he also has got numerous publications. So we have a rich panel with us, and I would appeal to all those in the audience to make useful use of this opportunity and direct your questions. And I would request Dr. Mithilesh Nayak to put these in the chat box. And till such that time that we get questions in the chat box, maybe I'll kick off with our discussion. And we will possibly try and talk mostly about the ADA ESD guidelines, but our panelists are welcome to pitch in and refer to other guidelines that have also come up in recent times, as Dr. Mithilesh Nayak correctly pointed out. So every year, I think we eagerly wait for the ADA ESD guidelines. And sometimes, I find that our students say that this is not correct because ADA ESD guideline doesn't say so. Whether we should be absolutely almost like blindfolded, follow these guidelines is another question. And that's why uh, how to implement these guidelines in our context, in our country is also important. So, first of all, can I ask Dr. Anil Bansali, from your vast reading of the subject, uh, do you think the 2022 guidelines are significantly different from the last years? And if so, would you be kind enough to point out those important differences?
Yeah. Thank you, Shubhankar. Thank you for very, very kind introduction. This is a pleasure to say that these recommendations of 2022 by the ADA EST, in fact, they are envisaged in the 100th year of the insulin discovery. So this is basically a guideline of the centenary year. And that makes it a very important because they have been very widely revised, and it took, I think, a pretty long time because the references up to 2018 have been reviewed. Till that, it has been reviewed. So I think it took around almost 3-4 years to make these guidelines. So such a long period where we have been examined, very critically examined, precisely examined. So that makes also very important. So this time guideline has been, I think, more focused on a cardio-renal protection in persons with type 2 diabetes. That's one. Secondly, there are changes in the screening criteria for the diabetes, which is also very, very relevant, even in our scenario, where the large pool of the people with the pre-diabetes are existing, like in our own country. I will just have some discussion on that. And this time, I think the more focus has been put on a DSMES, that is a diabetes self-management education and support, which was not so earlier stressed in that way. It has also been now this added the social determinants of health care system, physical activity behavior, and weight management as a target intervention, which was also not only part of the previous guidelines. So I think so many things have been included new. I'll just summarize for the audience, which I liked and which I found that there was something new. So just 2 minutes I'll give me. So one is about the screening for diabetes. In a screening for diabetes, earlier the age cutoff was 45 years, which has been now revised to 35 years now. So everyone individual who is asymptomatic should be screened from the age of 35 years onwards. But I think the new addition which has been done and which is very remarkable, that anyone who is having
So, regarding this age cutoff, Anil, we should be happy that this is coming closer to what we have been recommending for our physicians. Yeah.
Yes, exactly. So I'm very happy that, and really in our own country, the studies like the masala study, they showed even a prevalence of a diabetes prevalence of a pre-diabetes something around as a 72%. So such a large pool of people with diabetes, pre-diabetes are going to convert into diabetes in the future. So screening at a younger age, so 35, one. And secondly, above 18, particularly in those who are having a BMI of 25 by Western, and for our Asian Americans, they have used the word Asian Americans rather than age. Fine. So that is, I think, that more than 23, along with one risk factors. So these risk factors are same what we have discussed earlier. So that is one, I think, a remarkable change in a screening this they have done. Secondly, this time they have also focused on DSMS. Why I'm stressing on that? Because the COVID has taught us so many things. And during the COVID period, your digital consultation, your telemedicine, and you see that how the world has fought against the COVID in almost a span of 2 years, and we have overcome the crisis. So I think more focus has been given that each person with diabetes should be equipped with his own self. He should be involved in his own management. So that access should be given to him. So this is a part of a self-management, whether it is an education program or whether it is a access to medicines or whether it is an access to consultations. So many things. So diabetes, self-management, education and support, each person with diabetes should be connected to it. And they have identified really the 4 periods in life where they do really require. One is a diagnosis. Second is yearly or annually they should undergo. Thirdly, when they are failed to achieve the targets. and lastly, when there is any complication happens in those patients, and finally, when they have a transition in life. So I think there are 4 or 5 points in lifetime when you really require the preventions, and you really require that each patient should have an access to this program, and everyone is involved in, everyone should be involved. The patient should be self-involved in his own management. They have also talked about the health care system, and this includes not only the previously we used to talk about the diabetologists, endocrinologists, physicians, surgeon, and all, but this time they include a huge number of the people. Dentists have been included, foot nurses have been included, foot surgeon have been included. So many patients, so many team members have been included to make it a comprehensive team. And a word about the physical activity, which has appeared remarkably, I think, this time. We have put in a stress on prolonged sitting. So this time, the highlights is on that after every 30 minutes, you should have a light walk. One. Secondly, they have also talked about the how many steps you should walk. It was always a contentious issue, 10,000, 5,000, 8,000. But now they just tell, even whatever you are walking every day, but even if you walk 500 steps a day, you reduce the risk of cardiovascular events by 2 to 9%. And even if you do a 5 minutes brisk walk, you increase your life expectancy by 4%, 4 years. So I think that they have talked about the sleep this time. So that's a very important, less than 6 or more than 8, and the quality of sleep. And they have also discussed about the chronotype. Going back to the at late night is also detrimental. And lastly, they have also talked about to reach sarcopenic obesity to overcome this, like particularly for our Asian phenotypes, where we are obese but having a sarcopenia. So they have advised not only the brisk walk or a 150 minutes walk or a 75 minutes walk, as it may be depending on intensity, but they should do resistance exercises for strengthening the muscles. So more on physical activity. A word about the weight management that has been now as a target. So one should achieve this target by reduction of 5 to 15%, and they are not shying in telling that it is beyond lifestyle. You can use the GLP-1 agonistic analogs and your newer drug like GIP and GLP-1 like your tirzepatide. So many, I think, things have been included. And now lastly, finally, a word about the major bulk of the diabetes who are having either multiple cardiovascular risk factors or ASCVD. I think very clear cut, they have been focusing on GLP-1 and SGLT2, heart failure, SGLT2, and even now they have segregated patients with CKD with albuminuria, without albuminuria, but declining renal function, SGLT2, if contraindicated or not tolerated, then GLP-1 agonistic analogs. So I think majority of the patients, almost I feel that 80 to 90% of the patients will come into ASCVD or a high-risk group. So every person should be on a metformin, lifestyle, and SGLT2 inhibitors, and then the GLP-1 receptor agonistic analogs can be added if you are not able to target. Insulin has been slightly lagged behind this time. We have first focused on a more GLP-1 to begin with, and then then later on insulin. So I think what I could gather is
Thank you. That's wonderful. It's in a capsule. So I'll now turn to another very senior endocrinologist of our country, Dr. Subhash Wangno. What do you think about these guidelines? How suitable and applicable are these for our country? And Dr. Wangno, because of his internet connection issues, has decided to keep his video off.
Thank you, Shubhankar. And I would like to start by adding a small comment on the earlier question taken by Professor Bansali. Personally, I think sooner or later, NAFLD or the fatty liver will be included, as this is one of the interesting intersecting areas of an endocrinologist and gastroenterologist. Now let's come to whether the guidelines suitable for India or not. If you look over the way the guidelines have changed more towards inclusion of obesity and cardiorenal endpoints, this will have to be included sooner or later with the way its incidence is skyrocketing across all age group and the gender categories. Let's see. Guidelines give you the best possible evidence that is there currently, but they are not cast in stone. They always give a wiggling room. They can always be adapted to the local flavors and the requirements, like we have the RSSDI guidelines that Dr. Bansali alluded to, which are based on these guidelines. I would like to see more emphasis on the use of AGI, especially in our population where the post-meal excursions are quite phenomenal. Metformin, as Dr. Bansali told, is there as the first line with the option of using either GLP-1 based therapy or an SGLT2 if the situation so demand, whether the patient you want to reduce the ASCVD or you want to reduce the CKD or HHF. The next options are the same after the GLP, SGLT2 or the metformin is the first line therapy. The next options are the same as they have been for the years in the previous guideline. But yes, with the increasing trend to the young CVD, particularly in our country, which is part of the world, these guidelines cover up a good ground. And Dr. Shubhankar told initially that we are not bound to follow these guidelines. They are there to give the best possible evidence till date, but we can change them as depending on the local flavor, the Indian phenotype, what are the different clustering of the different phenotype in the Indian population, and more or less we can manage our treatment guidelines based on our own guidelines, RSSDI, and still in our country like India with the poor financial resources and the patient is to pay from his own pocket, we have to be more pragmatic, practical in writing a prescription for any diabetes, looking what is the best evidence for the cardio-renal protection, and also that Dr. Bansali emphasized on the obesity in terms of physical activity. So this should be the ideal, suitable, the guidance, how we take in our Indian context. Thank you, Shubhankar.
Right. Thank you. Thank you. I, for one, thought, looking at the guidelines, that metformin has lost its position a little bit. So what is the current role of metformin? Let's hear from Dr. Vagish Iyer as to, is it exactly as it's enunciated in this guideline, or is it somewhat different in your practice?
You are muted.
Dr. Vagish, please unmute yourself.
Yeah. I think if we go through the guidelines, the use of metformin has been marginalized mainly for a glycemic control. That too, it comes after SGLT2 inhibitors and the GLP-1, and they go ahead and say that if somebody is on a metformin, if it demands that ASCVD is there in spite of a glycemic control, I think we need to add these agents. So I feel in the overall, their perspective, it is not useful for a cardio-renal management, but it's only marginalized for the glycemic management. If I bring our situation, I think in a socially deprived and our country like India, I think it continues to be an number one molecule based on the economic status of our patients, and also huge number of patients who are common garden type 2 diabetic patients do require a metformin. But when it comes to the risk management, I think it's been marginalized to the third agent rather than what it was first earlier.
Right. We come to Dr. Rajesh Rajput, and I understand that he has to leave a little bit early. Maybe then we'll take some of the questions also for him early. So, but still, what about the role of SU, sulfonylureas, which is still widely used in our country? But once again, if you look at the current guidelines, ADAC, it's mostly about SGLT2 inhibitors, GLP-1 receptor analogs. So what should be the position of SUs in our country? Once again, please unmute yourself, Rajesh.
Right. So thank you very much, Dr. Shubhankar. And first of all, I will like to start from where Vagish has left actually. See, when we are talking of diabetes, we are so much fantasized by SGLT2 inhibitor and GLP-1 data, CV outcome data, that we forget that majority 70% of the patient, when they land up in the clinic, that does not have cardiovascular disease or renal disease. And in all patients of diabetes, insulin resistance is a key abnormality. Metformin currently is a basically most useful drug to take care of insulin resistance. So we have to use this drug, whatever is its price. Still, there is no replacement to metformin as far as insulin resistance is concerned. And if we see all CV outcome studies, enrolled patients who were on background of metformin therapy. So from where this data has come, that we can start SGLT2 and GLP even without starting metformin prior to a patient. These are all sub-analysis or small analysis later on done out of these CV outcome studies, which are actually not powered enough to answer these questions. So we are not challenging the utility of SGLT2 inhibitors and GLP-1 RA, but to me, at the same time, being a cheaper drug, we should not negate the benefits of metformin. So patients should be given the benefits of metformin until and unless patient cannot tolerate that drug because of GI side effects. Now moving forward, coming to sulfonylurea. Now again, problem with sulfonylurea only to this word nowadays when we talk of evidence-based medicine, that sulfonylurea therapy is not backed by any large outcome studies. Being a cheap generic drug, no pharmaceutical company is actually willing to perform that large CV outcome trial. But considering its cost, considering its efficacy, considering the number of diabetic patients which are present in our country, considering their socio-economic condition, the average amount of money which they are earning in a day, sulfonylurea still holds a very good place in our country for management of type 2 diabetes. Not only that, even in circulation, there has been a meta-analysis which has clearly shown that even out of class of sulfonylurea, that is glimepiride, gliclazide, glipizide, and some others which are acting on different receptors like ripeginolide, netiglenide, even in patients who are having a pre-existing cardiovascular disease, there are safe sulfonylurea which can be used even these populations. So we should not be with this background in the mind that sulfonylurea are out of use in patients of type 2 diabetes. I think they have proved their efficacy. They are going to stay here, and especially those group of patients, which is a large chunk, who cannot afford a costlier medication like GLP-1 RA, which predominantly act on atherosclerotic pathway. Glucose control still is important. So sulfonylurea is still going to be used in large majority of us, and to be all of us who are today panelists, all of us are using. So they are
Right.
still having important role.
I think,
Right, so,
Shubhankar, let me just add one thing, that globally, if you see the market share of all the OADs, the SU capture the market share of more than 60% among all the OADs still till date. And you can see that how important is sulfonylurea in the management type 2 diabetes. I agree with Rajesh totally. Thank you.
Absolutely. However, a couple of points. One is, of course, those are post hoc analysis of SGLT2 inhibitors, CVOTs, possibly, which have shown that background use of metformin versus no background use of metformin. There were small numbers who did not have background metformin. The benefits of SGLT2 inhibitors were no less, possibly somewhat better in those who were not on metformin. And that's why possibly the greater emphasis on SGLT2 inhibitor.
But then they are not statistically powered, sir. They are not statistically powered.
Yeah. So the other part is, while you have strongly, and I do fully agree that sulfonylureas have shown, the newer sulfonylureas are likely CV safe, but are they CV effective in the sense that we have seen with the newer generation. So that's the issue. And now, Dr. Rajput, please be with us for an answer question that Dr. Harvinder Singh has put. Does combination of SGLT2 inhibitor and diuretic, is it harmful for kidneys? Which is the safest diuretic to combine?
Right. So Harvinder, I think you have to specify first at what level of CKD patient is on diuretic, because I believe until and unless patients of CKD are having a eGFR of less than 30 ml, where they start accumulating fluid inside their body, usually over beyond that, we do not use regularly diuretics. Anyhow, if patient is on a diuretic therapy and eGFR is more than 25 ml or 30 ml, which is the current DCGI recommendation, is use SGLT2 inhibitor more than 30 ml of eGFR, you can safely combine with the diuretic therapy, monitoring the patient for risk of hypovolemia and postural hypotension. That is our only observation. Otherwise, there is a lot of difference between a diuretic and an SGLT2 inhibitor. An SGLT2 inhibitor induces glucoresis. It induces glucose excretion and then osmotic diuresis. With the use of diuretic, there is rise in serum uric acid. With use of SGLT2 inhibitor, there is decrease in serum uric acid. With use of diuretic, there is increase in sympathetic nervous system activity. With use of SGLT2 inhibitor, there is no increase in sympathetic nervous system activity. So there are lots of differences between diuretics and SGLT2 inhibitor. And in a given patient, if need arises, we can use them, but we have to only monitor these patients very carefully.
And finally,
Yes.
Rajesh, the SGLT2 inhibitors reduces the
interstitial fluid more,
interstitial fluid more, while the diuretic they reduces the intravascular
fluid.
That's a major difference between the two.
Absolutely.
Besides hyperuricemia, which you have with the diuretics as opposed to SGLT2 inhibitors.
And of course, the issue that Dr. Harvinder Singh has, possibly the use of loop diuretics along with SGLT2 inhibitors. It's suggested that the risks of hypovolemia, as Dr. Rajesh has already mentioned, may be more so. There would be occasions where they may be needed. I think it's not absolutely contraindicated, but one has to be more careful.
One has to be careful.
Yeah,
absolutely.
I think with the use of,
Shubhankar, just one comment here, because the diuretics, the Harvinder asked this question, that up to the eGFR of 45, use the ditor or say loop diuretics, and below, below use a thiazide.
No. Up to 30 ml use dietide, less than 30 ml loop diuretic, less than 20 ml metalazone or some other type of diuretic.
Yes, but now the recent study, CLIP study, which published last year only in NEJM, which showed even the use of thiazides at a low eGFR, so even below 30, it was useful in controlling blood pressure and reducing the incidence of hyperkalemia. So refer to CLIP study.
And also we had to reduce the dose of the diuretics when we are combining with the SGLT2.
SGLT2, fine.
Absolutely. So this issue is well covered. So because Dr. Rajesh may be leaving us soon, can I also request you to talk about the role of DPP4 inhibitors, and if so, is there a choice amongst the DPP4 inhibitors?
Excellent question, sir. Well, we have seen an era where DPP4 inhibitors are discussed like anything. They are considered like a magic bullet. And then comes the era of SGLT2 inhibitor and now GLP-1. See, we have to understand, when we see a patient of diabetes, what type of diabetic patients we are seeing. Whether we are seeing a newly diagnosed type 2 diabetic patient who does not have any cardiovascular and renal risk. Now, when we are seeing such type of patient with no additional comorbidities, DPP4 inhibitors are a good drug to control hyperglycemia as well as to control hyperglucagonemia at the same time without putting the patient to the risk of hypoglycemia with weight neutrality. But when we see a patient of type 2 diabetes with established cardiovascular risk or established renal disease, then DPP4 inhibitor takes a back seat. Then probably SGLT2 inhibitor and GLP-1 RA scores over these drugs. Having said this, DPP-4 inhibitors are now oral drug, although GLP-1RA oral is also available, but then cost is a concern. They are probably having a minimal side effects. So a general physician has not to bother about much of the side effects like nausea, vomiting, seen majority of GLP-1RA, UTI, and vaginal infection, hypovolemia seen with SGLT2 inhibitor. So they are relatively safer drug. So physician feels confident about using DPP-4 inhibitor in a patient of newly diagnosed type 2 diabetes, which DPP-4 inhibitor to choose from. Now, in our country, we have lots of DPP-4 inhibitors available to us, vildagliptin, sitagliptin, saxagliptin, and so on. Now, if we see the efficacy, large number of meta-analysis do not focus on individual studies. Overall, if we see the glycemic efficacy, they are largely equal among all the drugs. Glycemic efficacy of a drug depends on baseline HbA1c. Higher the HbA1c at your starting, greater will be the fall in HbA1c. The lower HbA1c, close to 7% you are starting, lower will be the fall in HbA1c. What are the differences? Differences are, say, vildagliptin, it has to be used twice a day preferably. Sitagliptin has to be used once in a day. We have saxagliptin, again used to be used once in a day. We have another teneligliptin, which has to be used once in a day. But then with teneligliptin, there is an issue about QT interval prolongation, which US FDA and Japanese FDA document again clearly shows that sitagliptin has no effect on QT interval. There is a small effect of QT interval with the teneligliptin. Then comes renal safety. Now for teneligliptin, there is no dosage modification. For linagliptin, there is no dosage modification. For sita, saxa, and sitagliptin, you need to modify the dosage of the drug according to EGFR. Then the difference comes according to the established safety in CV outcome study. We have CV outcome study with sitagliptin TICOS study, where it has clearly shown its non-inferiority and safety actually. In contrast, with saxagliptin, there is increased hospitalization for heart failure. With vildagliptin, there are no CV outcome trials. With teneligliptin, there is an issue of increase in QT interval prolongation. So these are some subset of differences which has shown differences. With linagliptin, there is a benefit that with trials, it has shown that in patients who are having CK, who are having heart failure, as well as compromised renal function, the drug has shown as far as CV outcome is concerned. So these are some small subset differences, but to a patient, common garden type 2 diabetic, no difference, no cardiomorbidity, no renal morbidity, then probably as far as glycemic efficacy is concerned, these drugs are largely same. There is not much of statistical significance difference between them.
So if they're otherwise similar, I would choose the one which is the cheapest.
Absolutely.
Is that a fair comment?
Right. Absolutely. Agreed.
So at this point, so will sitagliptin be your choice?
No, sir. Sitagliptin is also cheap. Vilda is also cheap. Teneli is also cheap. So all are cheap. So I think we cannot.
With availability of more evidence.
With
evidence
definitely
more available.
Most evidence are available with sitagliptin. As far as
okay.
So definitely we will go for it.
Right. Good. And offshoot of your current statement is Dr. Sharma's question. Can we use DPP-4 inhibitors in patients at risk of heart failure? Which DPP-4 inhibitor to prefer?
Right. So as I have told you, with severe TIMI trial, where clearly it has been shown that with saxagliptin, there is increased hospitalization for heart failure. When it comes for use of DPP-4 inhibitor in patients with heart failure, I think the current data suggests that it is sitagliptin which is the safest to be used. Even linagliptin also has been shown to be the safest. So if you have to choose out of them, you can choose either sitagliptin or linagliptin.
Yes, but about the vildagliptin, I will add it here. the data are not robust for in a
Yes, sir.
patient.
Yeah.
Definitely.
That's why the CETA will remain a choice. And
CETA or
Lena,
Lena?
yes, Lena is also not. CETA will remain a choice.
Right. Thank you. So we come back to Dr. Bansali. So if you look at the guidelines, it says ASCVD, yes, or high risk for ASCVD, then your choice is either a GLP-1 receptor analog or SGLT2 inhibitor with proven efficacy.
Yeah.
Now, in our country, GLP-1 analogs are by and large out of the reach of most patients. I know Dr. Subhash Wangnu has a large number of patients on GLP-1 analogs, but his clientele does not possibly reflect the entire Indian population of patients with type 2 diabetes. So quite often one would straight away jump to SGLT2 inhibitors. But my question is, while the data about heart failure is very strong, are you convinced that SGLT2 inhibitors favorably influence the atherosclerotic process? Dr. Anil Bansali.
So I think if you dissect between the two events, one is heart failure versus the 3-point or a 4-point MACE events. I'll just summarize for you. Data from a leader trial showed that the GLP-1 agonistic analogs did better for a reduction in 3-point MACE, while they were not having a significant benefit for a hospitalization for a heart failure. So that was the one dissecting out the effect of the drug on cardiac myocytes versus coronary vasculature or a vasculature in general. On the other side, the SGLT2 inhibitor, very consistent on hospitalization for heart failure, means very beneficial on cardiac myocytes, but on coronary vasculature, there was some dilution. And moreover, this was only in those who already had an established ASCVD, they definitely had a better outcome as opposed to those who had a multiple cardiovascular risk factors. And if you recall that even the beneficial effects of the SGLT2 inhibitors was observed within say around 8 to 12 weeks initially, and it was mainly attributed to hemodynamic factors. Because the graph was separating between the around 8 to 12 weeks between the placebo and the SGLT2 inhibitors. But in the long run, overall, the outcome is better. Hospitalization for heart failure, so they do have a more beneficial effect on the myocytes and cardiac myocytes as a functionality, while on the vasculature, not so consistent. And particularly, even I think Dr. Wangnu will answer the next question, whether this is a really a class effect or whether it is an individual effect of a drug. But I think in a long run, by reduction in so many things, by reduction in your procoagulant activity, beneficial effect in lipids, and your improvement in oxidant profiles. So I think they might be having some effect even on atherosclerosis, which is not so well shown.
Dr. Bansali,
So
just one question.
The effect. Yes, please. Subhash.
Yeah, one question, Bansali.
Yeah.
So you think that they have a direct effect on the cardiac myocytes, and that is the one reason. Can we just extrapolate that because of the weight loss, because of the improvement in the insulin resistance? And the insulin resistance, we know that changing the ratio of the UCP1, the M2 to M1, increasing the concentrated UC1 through FGF23, and improving the insulin sensitivity, that might be one of the also reasons that because insulin resistance is also linked with the accelerated atherosclerosis. What do you think?
I think the early beneficial effect which you observe in months only. So that may be attributed to the fuel metabolism of the cardiac myocytes, more ketones, one. The secondly, which was attributed to the reduction in interstitial edema of the cardiac myocytes. That was another contributing factor. And then there was an increase in anosynthase activity was also predominantly shown with the SGLT2 inhibitors. That was another point. So I think there are some reasons for that. The more beneficial effect on the myocytes than on the vasculature. Because now you are segregating these two also. Because the GLP-1, they are put against that SGLT2 inhibitors. Against means you say against or a complementary. But one is predominantly having an effect on vasculature Another is
Another important mechanism, I think, where SGLT2 scores is probably they are acting from day one on sodium hydrogen exchanger. Now, sodium hydrogen exchanger subtypes are expressed over heart as well as kidney.
Yeah.
So that is why probably their benefits are much more than what we are expecting out of GLP-1.
So that is effective very early.
Yeah. So we'll come back to Dr. Subhash Wangnu soon, but we haven't heard from Dr. Vagish Iyer for a while. So Vagish, there's a question for you from Dr. Bharat Bhushan. So what it says is with the availability of generic SGLT2 inhibitors especially, have your prescription for DPP4 inhibitors decreased significantly?
Yes, definitely. In fact, right from the beginning, going through the benefits of a SGLT2 inhibitor, but they were beyond reach of our patients. So use of DPP4 was more. But with availability of SGLT2 inhibitors in the generic form, in affordable form, definitely the prescription for SGLT2 inhibitors have increased across the type 2 diabetes spectrum. And when efficacy wise, I feel there's one big thing which has happened in India is most medications are available in a generic form and they're quite effective also.
Absolutely. Great. Thanks. So
actually, just to add, sir, not in generic form, but Indian pharmaceutical companies, they are giving a good quality at a cheaper rate, even in a branded formulation.
No, they are branded generic.
Yeah.
Yes.
So
they are not generic, they are branded generics.
Branded generics.
Yeah, good. Yeah. So since we now have understood the great benefit that SGLT2 inhibitors provide to our patients, and now they're available at fairly good competitive prices in our country, we and our physicians need to know more about them. So can we have Dr. Subhash Wangnu once again to tell us, is there a choice amongst the SGLT2 inhibitors and any tricks of trade, how best to use them, whom to avoid, for example? Can we have some quick advice for our physicians?
Yeah, Shubhankar, structurally, yes, but do they really transfer into any real benefit in real world has been discussed many a times. All the available ones have almost similar efficacy regarding the glycemic effects and the side effects. The doses are different to start off with. Canagliflozin in higher doses, if you see, is having SGLT1 inhibition also, but does that translate into any additional benefit depends on the way you look at it. The statistics tell insignificant difference between the others, but at the end of the day, they have similar clinical efficacy. Now, on the basis of the currently available clinical trial data thus far and basic consideration from pharmacology and physiology, I can infer that both the benefit and the side effects of SGLT2 are part of the class features and not specific to the individual drug members of the class. Although one may be tempted to attribute the variable outcomes noted in some of the trials, one other trial I will tell you about the VATICV trial to gliflozin to drug effects. Highly variable outcomes were observed for all the SGLT2 that completed more than one trial, RCT. As with any other experiment are subject to noise, one should simply resist the tendency to follow the noise in the data. That is my request. In summary, I will tell you, Shubhankar, that as a class, SGLT2 demonstrate cardiovascular and renal benefit in patients with diabetes mellitus type 2 at risk for the cardiovascular disease, cardiovascular benefits in patients with diabetic or non-diabetic kidney disease, and heart failure benefit in patients with known heart failure with reduced ejection fraction or CKD with or without diabetes. So in a nutshell, this is my opinion about the different class of the SGLT2.
And is there a class of patients where you would not use SGLT2 inhibitors, where you would be careful about using SGLT2 inhibitors?
Of course, the SGLT2 basically we should not be using in patient with the very low GFR, number one. And the most of the agility they have shown up to 20, but still the recommendation is up to 30 we cannot use. Number two, increase the patient who have increased tendency for the GTI, particularly the postmenopausal females, then it gives rise to the increased incidence GTI. We should be very cautious about using SGLT2, number two. And number three, in patients of who have either, if you are using it alone, just basically for cardiorenal protection, and the patient's HbA1c is pretty high, you should not use, because you may have landed up in the, what you call the non-ketotic, this hyperglycemia, and a word of caution about SGLT2 should not be used during pregnancy, type 1 diabetes. These are absolute contraindications.
I think, Shubhankar, I'll just give one comment on it. I think the reasons of not using the SGLT2 inhibitors in clinical practice seems to be those who are either having a recurrent UTI or GMI.
GTI,
GMI or UTI. Or in our observations also shows that it is not only the women who suffer the most with that, but even the men also. Even the men also have a lot of balanoposthitis and GMI. And in fact, our many patients have really undergone circumcision for that. So that's one which we have observed. Yes, I think even if we take a history that how the patients are presented initially, suppose even they are presented with the diabetes at the time they had a balanoposthitis. These patients, even they might be having a good glycemic control, and if you add SGLT2, they again do have a resurgence of the balanoposthitis or fungal infections. So it is not uncommon in men as well. That's one. And now I think the three new studies which have come recently which show that we usually have a fear and scare. We are scared about to use in people with elderly or frail people. I think they can be safely used. And rather, it has been shown that they tolerate better, in fact. That's one. Secondly, it can also be used in acute decompensated heart failure. So you can use it even in that situation. Currently, we are using in a chronic heart failure or heart failure with a reduced function. But even you can use an acute decompensated heart failure.
Right. So actually the usage
and a small comment when it comes to efficacy, actually not promoted well in our country. Canagliflozin 300 milligram glycemic efficacy is far superior than glycemic efficacy of 10 milligram of dapagliflozin and 10 and 25 milligram of empagliflozin.
That I explained I told you that whether that translates into any additional benefit depends on the way you look at it. Whether it really benefits clinically or not, I am very doubtful about it.
Weight reduction may contribute to, even I think the data are not there, but it may contribute to improvement in cardiovascular events.
Yeah. So the usage of SGLT2 inhibitors has expanded, and as we find more confidence in usage in areas which were hitherto considered no for use of SGLT2. For example, in relatively acute settings, now there's more confidence in using this class of drugs in elderly as well. So that's welcome that we can use in a greater number of patients. So, and at this point of time, let me remind all of us that we have more than 1,000 people who have already logged in and listening to all these pearls of wisdom is being strewn by all these experts. And please do continue to put in your questions in the chat box. And I remind Dr. Raju that we have not forgotten you, and your question about pioglitazone, we'll come back to that soon. But before that, it's about the GLP-1 receptor analogs, which have got a pride of place in the current ADA-ESD guidelines, and which comes ahead of insulin, in fact, as the first injectable. That's what is advised, not only this time, even last time, in the last guidelines also. So what is your take on it, Dr. Vagesh Iyer? GLP-1 receptor analogs ahead of insulin.
Yeah, I think I have two things to tell about this. They are quite fair to the science, but totally unfair to the patient. We know that they are quite expensive, and we can't used in most of our patients. Even I can remember number of patients whom I have put this, and even those patients who have come back and told it's too expensive to continue. So it is fair on a science part to use ahead of insulin, but totally unfair when it comes to the practice. Most of our patients can't afford. That is one. Second thing, not only in India, even if you, when I discussed my friends in US and the UK, they told even their patients is a very small number of a patient they are using it. I feel still insulin remains to be a good choice for a glycemic control and injectable in our country. If our GLP-1 receptor analogs becomes economical, more affordable, definitely, then they'll find a place ahead of insulin.
Thank you for those crisp comments, Bhagesh. Now we come back to pioglitazone and we come back to Dr. Anil Bansali. So, Dr. Bansali, there's a question from Dr. Raju about pioglitazone being placed as third or fourth choice in many categories ahead of this. That. So, what's your take on the use of pioglitazone, and what dose of pioglitazone is safe to use, which of course presupposes that pioglitazone is not safe to be used?
Yeah.
Comments, Dr. Bansali.
So I think the pioglitazone has been in use in this country for many, many years. I think after the SGLT2 inhibitors and DPP4 inhibitors, its use has gone down. Some adverse reports about the bladder carcinoma and worsening of heart failure, I think they were the precluding factors for its not its use in clinical practice. But if you look to the studies available, I think this is one of the drugs which has got a very organ-specific effects. You see about the stroke, there was a 47% reduction in stroke in proactive trial. If you see for the CIMT, that is a carotid intima medial thickness. So it was, I think, the most effective for a prevention of a cerebrovascular accident. Even it had a beneficial effect on 28% decrease in reinfarction and 37% in acute coronary syndrome in a patient who had a previous MI. And it is very effective in NASH. And it improves your body phenotype that is more subdued than visceral fat. So many, many beneficial effects of pioglitazone, except only one important is it increases heart failure. Means already those who are NYHA grade 2, they may slip into heart failure. So it's a cardioprotective, it's a organ specific, it has got a beneficial effects on heart, kidney, liver, and carotid vessels, vasculature. And low dose pioglitazone has been recommended in this. So means you can use around 15 milligram in patients unless there is no heart. That is the only contraindication. You can use this class of drug along with the SGLT2 inhibitors, possibly maybe complementary. However, we don't have a data of it in combination, but I think more likely we are going to have a benefit.
Yeah, I think
Dr. Bansali, yes.
Yeah. I think this is a very good drug, provided we have to select the patient to use it. We can't use it as a blanket treatment for other agents. In fact, even when it was banned, I think we were in the part of the ESI, we were strongly made it come back in a short period. It came back. That was a great thing. We continues to use this agent even now, in spite of being a lot of dark clouds surrounding it. It's a very good drug, very good glycemic benefit in a selected patient. And there are some patients, even a 7.5 milligram, if we withdraw, their glycemic control goes haywire.
Right. So that brings me back to the question of the dosage. So 7.5 milligram is also available in our country and it's been used. I personally haven't used it widely, maybe very sparsely. So, Dr. Bansali, do you think it still is effective at 7.5 milligram? And then will it be shown of its adverse effects?
I think that we have published one study on this, the doses of pioglitazone. So 15 and 30, what we showed in our population is that in 15 and 30, the only difference, there was the glycemic benefits were not significantly different. Only the side effect profile worsened. So I think that 15 milligram is an optimal dose. 7.5 may be too low, 30 may be too high. So 15 is a middle path. I think a 15 will be useful to exclude heart failure. It's a good drug and it makes your body profile as a body phenotype as a favorable for the cardiovascular cause.
Vanka, I think 7.5 is not available anywhere.
But I think
available.
Two important, but two comments, Dr. Shivankar. First of all, lot of good things has been talked about. The drug is not bone friendly. So in large number of elderly population, we have to be careful. Those with
that's the question I was going to put. Yeah.
Then coming to 7.5 milligram, whatever trials Dr. Bansali has talked about, the benefits which he has talked about, the trials has been done with dosage of more than 15 milligram or even with 30 milligram. We actually do not have any data regarding these benefits with 7.5 milligram. So when we talk of exact science, I do not know 7.5 milligram. Then why not we can use 2.5 milligram?
No, because there is a data available on a 7.5 milligram, a Japanese study, 2015.
No, but then those data are not hard outcome data.
That are glycemic benefit. Not
no, we are talking of we are talking of benefit on CIMT. We are talking of benefits on stroke.
Different. Yeah.
So those data are not available with 7.5 milligram.
Yeah, that's
so. So these are some important questions which are surrounding this 7.5 milligram dosage. Actually, that is my take.
Vagesh, you are right with that. Japanese use the minimum dosage. Even the sitagliptin is not available in the dose of 100 milligram in Japan. It is only available with 50 milligram. And because of the body surface area, the height and everything, they might be using, and they have shown something different kind of response because of different distinct phenotype. And surprisingly, that the sitagliptin 100 was never available in Japan, only the 50 milligram. Same way, they might have started using the low dose of pioglitazone.
Yeah, I know that was mainly came out of the thing with a bone friendly outcome.
Yeah.
And pioglitazone, when we use, mainly we use for a glycemic benefit, never for a, because hard atherosclerotic, we have got a better drugs to use.
Right. So we have to wind up, but maybe there so many other important areas to cover. But what Dr. Anil Bansali did point out in how is this year's recommendations or guidelines different from previous ones is the stress on social determinants of health, which are all very important and which, of course, runs through our mind whenever we have a patient in front of us. So how do we actually quickly assess the social determinants of health when a patient is sitting in front of us? Dr. Subhash Wangu, practical tips for assessment of social determinants of health.
We are not able to hear you.
You're not able to hear?
Yeah, you can repeat it.
Okay, so how can we practically and quickly assess the social determinants of health, which are so very important, we do understand, in treating a chronic disease like diabetes?
So I think this is a very difficult one, a very gray area. And there is increasing traction within the medical field for improving social history taking and integrating more formal screening for social determinants of the health within the clinical practice. And Shubhanka, there is also a growing number of high quality evidence-based reviews that identify interventions that are effective in promoting health equity at the individual patient level and at broader community and structure level. Now, reasons to do so are multiple, including providing whole person care rather than focusing only on the disease. That is number one. And number two, reducing missed opportunities for diagnosis by having all the important information in terms of living condition and social context. And number three, which is very important, reducing revolving doctor medicine and recurrent emergency room visits by understanding and addressing the underlying causes of the presenting health issue. And fourth, providing more cost-effective care by intervening early and preventing hospitalization, increasing adherence to the medication, improving health by prescribing medication that patient can afford and are therefore more likely to take regularly and as prescribed by the physician, and providing more trauma-informed and structurally competent care. These are the important social determinants of the health within the clinical practice of a SCP.
Absolutely. Purchasing power, cost of medications, and all that are extremely important. Another important area, I think, the amount of family support that is there. That's also important.
That is the whole person care, the family support, everything, which is important rather than only focusing on the patient disease.
Right. Fine. So finally, we have a question from Dr. Pathak in newly diagnosed young type 2 diabetes with A1C around 8.5. Which one is the best combination to start with? Does choice differ in elderly? If Dr. Rajesh Rajput is still with us, will you kindly take this up? Otherwise, okay, Rajesh has left us.
Can I answer, Shubhankar?
Yes, absolutely.
Yeah, I think as per the latest ADA guidelines, we see that a combination of FDC of the two drugs has been recommended when the HbA1c 1.5% above the target value of 7, that is up to 8.5. If you have a 1.5% above the target value of 7, that there is an initial recommendation that you can start the starting drug with the dual combination FDC of a gliptin, metformin, or a gliptin and the SGLT2. And in fact, ACE guidelines says even at the baseline HbA1c of 7.5, we can recommend the use of the dual combination FDC of a gliptin, metformin, or the gliptin and SGLT2.
I think Shubhankar, in this era,
I
think that in this era, we should talk about that the first choice for a newly diagnosed type 2 diabetes should be, if you use a combination, even at a hemoglobin A1C of 7.5, should be metformin and SGLT2. Because the cardiovascular risk factors are highly prevalent in Asian populations, and our more than 90% of the people are either having, because obesity is one of the important, they might be having abdominal obesity, may not be having general.
I think, sir,
the best combination, it is not the DPP4, it is the best combination is SGLT2 and metformin to begin with.
Just a small,
if you are not able to achieve the target, then basically you should go for a third line drug, wait for 3 months, see for hemoglobin A1C. If you achieve, it's fine. Otherwise, I think the
verified trial.
A small comment. All actually, this is a question where nobody can be 100% correct. Now, having said this, if we consider two different approaches, one is waiting for 3 months stepwise approach, another is pathophysiological based approach. If we consider the concept given by D. Fronzo et al., probably we have not to wait for 3 months. Right from day one, we have to start drugs which will target multiple pathophysiological defects. And with the availability of GLP-1 RA in an oral formulation, if cost is not a constraint, and when obesity is so rampant, specifically visceral adiposity, even starting with an oral GLP-1 RA along with metformin also makes a good case. Then we can also add SGLT2. But then cost definitely is going to make a big difference. And if that is an issue, then probably DPP4 inhibitor, metformin, and SGLT2 inhibitor are a wonderful combination to start in any patient of newly diagnosed young type 2 diabetics.
I think Rajesh, combination with a 2 drug is good enough. Adding a DPP4 inhibitor, you can definitely wait for 3 months and see the target is achieved. Use a 2 gram metformin and a full dose or optimal dose of SGLT2 inhibitor will definitely give a target hemoglobin A1C in many patients in the newly diagnosed type 2 diabetes.
I think if you look into the pathophysiology, DPP4 with SGLT2 inhibitor, I think addresses most pathophysiological defects in type 2 diabetes.
Absolutely.
I think Dr. Pathak would have realized why experts are called so. I think that's because they all have different opinions. So finally, I think
because even if you use a metformin and SGLT2, you target 3 defects.
Yeah, here 6 you'll address almost 6.
If you use a combination of 3, I am using a combination of 2.
With the 2 DPP and SGLT, you will target 6 defects.
Yeah, 6 DPP4 and SGLT2 inhibitors.
Yeah, will target 6 defects, Anil.
But the major abnormality, insulin resistance, will remain untargeted.
SGLT2
I
inhibitor
told you
reduces weight.
SGLT2
It
improves the
improves.
insulin resistance. I told you the reason, the
That is
mechanism.
a very modest effect.
So, so, so it's time for Dr. Shubhankar to wind up.
Yeah, right.
No, yeah. So I think it's there are different ways of reaching your target. That's possibly the message that comes across. And also, of course, you have to individualize, keeping your particular patient in mind who is sitting in front of you. So there'll be different issues. And also, you've also raised a very important question, Dr. Pathak, whether the choice will differ in the elderly. So there could be different issues that we have to consider in an elderly individual with newly diagnosed type 2 diabetes, where possibly we are not going very strongly for strong HbA1c lowering may not be our first aim. So I think we had a wonderful discussion, and I'm really thankful to all our panelists, Dr. Bansali, Dr. Wangno, Dr. Iyer, Dr. Rajput. And Dr. Rajput, despite having said that he may have to leave early, I think because he found the going so interesting, he remained right till the end. Thank you very much.
I am traveling, sir. That's why I requested that.
Okay. Right. So I think we had a wonderful session, and I would like to wind up saying or pointing to a recent paper in the Annals of Internal Medicine only a few days back, which looked at metformin versus SGLT2 inhibitor versus GLP-1 receptor analog as first-line treatment in type 2 diabetes. It was not a real world study, it was not a prospective study, but it was a modeling study in US population. And what it did suggest is if you start with GLP-1 or SGLT2 inhibitor, then you at the end of, I think, 3 years, you are likely to get about a 5% lower incidence of heart failure, myocardial infarction, or stroke. You are possibly going to increase the lifespan, the longevity, by 3 months for SGLT2, by 3.4 months for GLP-1. However, in order to be cost effective with metformin, for US prices, not our, of course, Indian costs for SGLT2 is much better. It suggested that the cost of SGLT2 inhibitor has to come down by 70%, of GLP-1 receptor analogs have to come back by 90%. So the conclusion was possibly still metformin remains cost effective as first line treatment. I mean, that was a paper that I wanted to just share with all. So thank you once again, and thanks to all the wonderful audience, and more than 1,000 of whom have joined in. And I'm sorry we could not take all the questions. Would the panel be sporting enough to take a couple of more questions, quick ones? Are they okay?
Yes, sir.
Okay, thank you very much. So, quick one. First of all, Vagish, Dr. Jain asks, which OAD to choose in patients of type 2 diabetes with osteoporosis? Non-osteoporosis.
Metformin, DPP4.
DPP4 sounds good. Okay, right. And Dr. Madhu Bashod comments on the use of oral semaglutide. Maybe Dr. Wangnu.
Yeah. What is the question, Shubhankar?
The question is about use of oral semaglutide. What are your comments? Where do you use them?
Of course, yeah. Though I have a huge number of patients on oral semaglutide, but I choose my patient very carefully and cautiously. First of all, I see whether the patient is able to afford this drug or not. That is the first indication to write this drug or not. And usually we don't find any difficulty in the corporate hospital. Number two, the patients who are desirous of weight loss despite their best efforts by doing diet and exercise, beside their best effort on the metformin and the SGLT2, they are not able to lose weight. Then I tell them there's another drug which is costly. You can add on the ongoing drug to have extra glycemic benefit as well as extra weight reducing effect. So far in my clinical experience, I have a data almost around more than 100 patients. I have been following from the day they were started 3 milligrams, 7 and 14 milligram. There were 5% withdrawal rate because of the intolerance, GI intolerance, particularly when they reached to the 14 milligram dose. 3 and 7 milligram was well tolerated. And on record, the patients who are on 14 milligram dose for the last now more than 3 months, which are on record, the maximum weight loss I have seen around 8 kg in my patients with a baseline BMI of more than 28. So that is my personal experience. And the drop rate is primarily because if you don't teach the patient how to take it, and you have to slightly titrate the dose. In fact, sometimes if the patient is able to tolerate 3 milligram, I even continue for more time before I step up to the 7 milligram. And even 7 milligram continue for a longer period of time, then go to the final 14 milligram dose. So that is the one. I think the tolerance rate is good, 5% dropout rate in my whole practice among more than 100 patients so far on record. So this is my
Great.
perspective.
Yeah, thank you. So essentially, who are significantly obese, that's the group that you would possibly try and use oral semaglutide. Right. So now, Dr. Rajput, if you're still around, Dr. Pathak wants to know about using 3 oral agents at lower doses, maybe a single formulation or separately, rather than full doses of the 3 different drugs. And he draws an analogy to treatment of hypertension.
I cannot get the question actually.
So what about using 3 oral agents at lower doses, less than the maximum dose, like in management of hypertension? That's his question.
See, it is not lower or higher dosage. It is effective doses. Now, the effective doses we decide according to their clinical efficacy, which has been established, whether in the clinical development program, as far as for diabetes, the glucose lowering efficacy is concerned, and then for pleiotropic benefits, various CV outcome trials, wherein in a particular effective dose, the drug has been used. So there is nothing like a lower dose or a higher dose. There are always standard dosage for at least anti-diabetic agents. Now, say for sulfonylureas, the most commonly used drug. For sulfonylurea, the dictum is that when you increase the dosage more than 50% of half the maximal marketed dose, there is not much benefit in terms of glucose lowering. Say, for example, glimepiride. If you increase the maximal marketed dose as approved by DCGI is 8 milligram. But when we go beyond 4 milligram, already it's more than 80% glucose lowering efficacy is achieved. So you are not going to achieve much beyond that. Same, say now you go for metformin. The optimal dosage, which must be achieved in majority of patients of type 2 diabetes, is 1.5 to 2 grams in a day. Beyond 250 milligram, there is not much benefit. For DPP4 inhibitor, there is a single efficacy, glycemic lowering efficacy. With normal renal function for sitagliptin, it is 100 milligram. For vildagliptin, it is 50 BD. For saxagliptin, it is 5. So for at least anti-diabetic agent, we have glucose lowering efficacy dose defined in RCTs. And for pleiotropic benefits, we have outcome data. So I think this question cannot be answered like that. What we are doing with anti-hypertensive medication, we can do it with anti-diabetic.
Thank you. And the final question goes to Dr. Anil Bansali. Dr. Joseph has asked raised a very important issue. So we know about the strong weight reducing effects of GLP-1 receptor analogs, and especially dual GLP-1 GIP receptor analogs like tirzepatide can lose weight even up to 20%. But why is the A1C reduction still stuck at about only 1.5%? Yeah. Whereas if you look at Dr. Roy Taylor's studies, 20% weight reduction has the potential to remit diabetes in many individuals. So why can we not get 2%, 2.5% and higher A1C reductions?
So one has to understand this, the weight reduction and hemoglobin A1C decline, they do not go hand in hand. You use insulin, you gain weight, but still the hemoglobin A1C goes down. You use sulfonylureas, the weight goes up, but the hemoglobin A1C goes down. So the important point here is that you might be having a weight loss of around 20 kg, but the hemoglobin A1C is 1.5%, depending upon the existing beta cell functionality. So if the existing beta cell functionality is low, your hemoglobin A1C will not be parallelly go down according to the weight reduction. So I think one has to understand this, that the weight reduction and the hemoglobin A1C reduction, they do not go hand in hand, and all status depends upon the existing beta cell functionality.
Thank you very much. I think we had a wonderful session with all our four panelists putting in the best effort, and of course being stimulated by those wonderful probing questions by our audience from around the country. And I'll be feeling in my duties if I do not extend my thanks to the team of INTAS led by Mr. Amit Arora, who has persevered with this effort of educating physicians, of making interesting sessions month in and month out over the last more than 2 years or so. So with these few words, I hand over the mic back to the organizers. Dr. Kurovila.
Yeah, thank you, Doctor. Thanks a lot for that. And very good evening, doctors. Today again, we could invite a very great discussion on the most sought about topic on the new guidelines. And the lively nature of the discussion itself shows, how much interesting the entire session was, whether it was the panelists, we as a host, or even the attendees was completely engrossed on this topic. I am sure, the audience will agree with me that the panelists could discuss in great depth, go into details on various newer changes which the guidelines has brought in. And I'm sure there would have been a lot of learning for all the attendees today in this program. On behalf of Intas Pharmaceutical, the makers of Dapavel, I'd like to individually thank Dr. Anil Bansali, Dr. Subhash Wangnu, Dr. Vagesh Iyer, and Dr. Rajesh Rajput for sharing their expertise and also keeping on stimulating the discussion by bringing in one or the other new aspects, and increasing the scope of the discussion. Endocrine talk show has gone from strength to strength, and every time we have done this program, we have crossed the numbers beyond 1,000 and 1,100. Today again, 1,279 doctors presence was there. It clearly shows, how the audience has been hooked on to Dr. Shubhankar Chaudhary and the newer, interesting topics he every time comes in, and the beautiful moderation doctor has been bringing in. And I think the audience and we ourselves as a host would like to extremely be thankful to Dr. Shubhankar Chaudhary for helping us to build such a great academic session for the Indian practitioners. I'm extremely thankful, Doctor, once again for your being the guiding light for this program. I would like to individually thank all the attendees, almost 1,279 of them, as I said, for sharing their weekend. I'm sure you will keep on supporting this program from month to month as we, curate newer topics, which will be clinically relevant for each one of you. Thank you, Doctor, and thanks, panelists, and thank you, Dr. Shubhankar.
Three cheers to Dr. Shubhankar. Three cheers.
Cheers to all of you.
Great show, Shubhankar. Great show.
Yeah.
Wonderful discussion.
Thank you. Thank you.
Thank you,
Anil.
Anil. Thank you.
A great week.
Vagesh. Thank you, Raja Rajput. Thank you, Amit.